Good morning, everyone. Welcome and thank you for joining us for our virtual Lunch and Learn this morning. My name is Sierra and I am the Supportive Care Services Coordinator here at Ironwood. I assist with the creation and implementation of classes that help our patients to gain healthy lifestyle habits and become actively involved in their journey to wellness. Today, our presenter, Dr. Ambrad with Ironwood Cancer and Research Centers, is with us to present on stereotactic radiation for lung cancer treatment. Please join me in welcoming Dr. Ambrad. Thank you, Dr. Ambrad, for joining us.
You're welcome. So today I'm going to discuss stereotactic radiation treatments for lung cancer. We're going to start off by laying some groundwork and some fundamental basics so that you have a good understanding of who this applies to and what's involved. And then I'll try to get into some details of the specifics and the logistics of the actual treatment itself, and then round that out with some discussion on side effects and outcomes. So we'll kind of go in that manner. I work in our Scottsdale office at Ironwood Cancer Center. I've been with the group since almost the inception in 2006, and we've been utilizing stereotactic radiation treatments now for close to about 10 years. So we have a lot of experience with this here at Ironwood. Stereotactic radiation. Basically, this is a modality that has been picking up a lot of steam because it is a way of effectively treating small lung cancers, usually early stage lung cancers, stage 1 and sometimes stage 2A lung cancers, in lieu of doing actual surgery. And I'll kind of get into the background of why surgery has been the standard. Essentially, a patient gets diagnosed with a lung cancer. If it's less than a 5 centimeter in size tumor, which is about 2 inches in size, then that's considered early stage lung cancer if they don't have any positive lymph nodes. Once a patient develops positive lymph nodes with lung cancer, those are more advanced lung cancers. Those are treated differently with more protracted regimens of radiation, often with chemo. So we're talking about a small subset of patients who have early stage cancers that are node negative. They have a tumor which is typically a 2 to 3 centimeters in size, which is about an inch or smaller. That's often picked up on a screening scan because they have a history of smoking, so their pulmonologist is checking them for lung nodules, and they happen to notice a nodule that may have actually been there for some time but now has grown or changed in size. The other time we find these tumors are when they're what we call incidental findings. They go in for a chest x-ray for a procedure of some kind that they have to do at the hospital, and lo and behold, they find this previously unseen nodule in the lung, and then they work it up and they find a lung cancer. So we're talking about early presentation lung cancers. So historically, what would happen was a patient would go to get the diagnosis and they would go see a surgeon. And if they were medically fit and they were okay with surgery, then they would go to surgery and have what's called a lobectomy, and their entire lobe of their lung would be removed. That is the correct oncological procedure. Instead of just what we call wedging it out, you would actually remove the entire lobe. So you had to be medically fit for this. But when you did this, you got pretty good results. You actually, for stage 1 lung cancers, will often see close to a 90% control rate, depending on the size of the tumor, of course, for patients with early stage lung cancer. What they did then was said, okay, we have a patient who is not fit for surgery, but otherwise has an early stage lung cancer. But if we take him to surgery, it'll be too dangerous. So let's do some radiation. And so that's what we would do. And we would give them radiation treatments once a day, 5 days a week, Monday through Friday, for up to 8 weeks of radiation. So something like 40 treatments of radiation. And when we did this, the results we would get would pale in comparison to surgery. We would only get 40% to 50% control rates, even with 8 weeks worth of radiation. So that led investigators to kind of declare that surgery is the preferred treatment. It's the gold standard because it has better control rates. And so it stayed that way for a really long time. And then some doctors actually in Japan started to develop this technology where you use a special tracking software and a specialized technique on specialized machinery, and you can essentially locate the tumor very accurately, and you can deliver a much higher dose of radiation per treatment than you would previously. And that allowed these doctors to actually shrink the course of radiation down into just 1 week typically, so usually between 3 and 5 treatments. So what you did was you took the biological effective dose, is what we call that, of an 8-week course of radiation and condensed it all down into just 1 week. So it's like a supercharged form of radiation, if you will. And when they did this, they found something very interesting. What they found was that the control rates in these patients who received this kind of approach were basically the same as if they went to surgery. So they were getting about 90% control rates with these shortened courses of radiation. So that led to a bunch of other studies, which then led to a randomized trial that was done in this country, where they utilized a 3 to 5 course regimen of radiation, and they concluded the same results. So this was more scientifically done and not just experiential. It was more in a study form, and they got about a 92% local control rate, which is very favorable and essentially exactly the same as surgery. So that's the current state of affairs. And the next level of studies are now looking at patients who are actually operable patients. So these are patients who could undergo surgery, and we are now randomizing them between surgery and stereotactic radiation. There are actually 8 such studies going on right now across the world, none of which have yet been published. We are eagerly awaiting these because our belief is that even if they are exactly identical, then technically stereotactic radiation will become the new standard, because that doesn't require surgery. And of course, surgery is much more expensive and can be much more dangerous than a non-surgical approach. So based on that information, it is now standard to offer this kind of treatment to patients. We always explain the background of surgery so they have a good understanding of their options, but this is an exciting time for us in radiation for early stage lung cancer because of these results from this approach. So that's the background. So what exactly is radiation, and what is stereotactic radiation? So radiation therapy is essentially an X-ray, just like a chest X-ray or a dental X-ray, except that it's much more powerful than those kinds of X-rays, and it imparts an effect on the tissue where it can kill or break up the DNA of cells inside the body. And what cells we're targeting in this case are lung cancer cells, and any cancer cell is trying to divide, it's trying to grow, and what happens is it opens up its DNA, it doubles a copy of itself, and then it creates another clone, and then each clone keeps doing the same thing. So a tumor is growing because its DNA is doubling and exposed. And the target of radiation is the DNA. So what we're doing is we're attacking the cell at the nucleus, essentially. And so this form of radiation, it's called ionizing radiation, destroys the cells at the nucleus. It also will affect normal tissue because it's an X-ray, so radiation will go through your body till it hits the target and then keeps on going out the other side like a bullet, basically. But our normal tissues can repair themselves better than a cancer cell can. So we call that a therapeutic window, and that is how radiation works. The normal tissue does get some radiation, it takes on some damage, but the normal cells repair themselves. Cancer cells have a harder time to repair themselves. And if we get it at the right time, we get it with the right dose to the right locations, then we have, more often than not, we'll be able to eradicate those cells. That's how radiation works. So we're essentially sending an X-ray into the body to the target. But in this case, stereotactic means we use a specialized software which hones in on the target very precisely, so I can deliver a very small margin of radiation around the tumor instead of a larger margin to account for setup uncertainties in setup, or patients coughing or moving and things like that. So we use this very tight form of radiation. Some patients will often ask, is it a laser beam? Is this laser radiation? It's not heated radiation like a laser, but it acts like a laser beam because it's so targeted. So that's the concept of stereotactic radiation. And so what we do is a patient will come in who, after their diagnosis, we will often obtain what's called a PET scan. A PET scan is to help stage a patient so we can see if the tumor is not spreading. So for stereotactic patients, it requires that the tumor is not spreading. And the other thing a PET scan does is it gives us an outline of a cloud, if you will, of the actual motion of the tumor. So as you know, you're breathing, and when you breathe, your lung is moving up and down, kind of bobbing, if you will, like a bobber on the end of a fishing line. The tumor in your lung will kind of bob up and down, and in some cases rotate in different angles. And that's just based on your breathing cycle as you move up and down with your breathing. And so the tumor is actually moving. What the PET scan allows us to do is it allows us to target the movement or track the movement of the tumor itself, because the scan is given slowly over some period of time, and the tracer we use will basically glow in the areas where the tumor was present. So you can get over what we call a slow scan, and over kind of a smeared image, if you will, we can actually see where the tumor was in time. And so we use that as an outline to help us guide where the tumor will always be. We also do, again, slow scans, which help us see the breathing cycle more slowly, so you get a maximal coverage area of where the tumor was touching inside the body. And that becomes our target. And then we put a little bit of margin around that for uncertainties like subtle shifts or coughs or things like that that can happen during the setup process. So a patient gets this PET scan, then they get what's called a mapping, which is a simulation, we call it, which is essentially a dry run of how the radiation treatment is going to go. And what that means is you come in your regular street clothes, we take your shirt off, we lie you down on a table, you have your arms up above your head, and we immobilize you in the position that we want to treat you in, and we put you on a CAT scan machine. And this CAT scan machine takes a 3D image just like a regular CAT scan, except we use a slow technique like I just described to capture the full motion of the tumor. And you get the CAT scan in the treatment position, and we use a specialized device called a compression device to help you not breathe as deeply as you normally would when someone tells you to relax, which is actually counter to what we want you to do. We actually we want you to relax, but we don't want you to take deep breaths. So we use this device that pushes down on your belly when you try to take a deep breath to remind you to breathe more shallow. And that's the setup for our stereotactic radiation treatments. Once you get the scan, it is piped over into our planning computers, and then the planning process begins. You go home, and about a week later, roughly, the treatments will begin a week afterwards. So during that week after planning, you're relaxing at home, and we are getting to work on the plan. And so what we do once we get the image and we get the information is we take your PET scan and we fuse that using a software program, into the images we just took in the simulation position, and then the computer can see and overlap exactly where you are on the table compared to where the tumor was on the PET scan. So it's a really nice tool to help us really hone in on the target. And then I get in there on my computer and I create a field, or what we call a contour, of of that target, and I tell the computer, this is what I want you to give radiation to, and all these other things I'm contouring, I want you to avoid radiation as much as possible. And so what we do is we run a series of plans, typically 40 plans when we call optimize a plan. And this allows us to pick the best plan. And we tell the computer there's too much, so we do an iteration, and the computer will say, okay, here's what I came up with. But I, as the physician, will take a look and say, no, you need to do a better job on the ribs, or this is too close to the heart, or this is too close to the aorta, or whatever the case may be. And I tell them, try again. And we usually end up doing this over and over again until we get the most optimal plan. And then once the plan is ready, we then QA the plan. We have a team of physicists that double check that what we think we can deliver is actually deliverable by the machine itself. So we do a test run on the machine to make sure everything is lining up and giving us what we expect to see. And then that's when the patient comes back and starts the treatment. And then on your day of treatment, you essentially get in the exact same position you did for the mapping session. We lie you down on a table, your arms are above your head, we immobilize you, we have you in a position where you can't move, and the device is usually pushing on your belly. It's called the compression device. And then we do an image of your body in that position on the machine. And this is called cone beam, which is a technique we use to take a movie of your actual positioning right before we actually do the radiation. It's another layer of assurance where I can target the actual tumor, so I can actually see in a movie form, if you will, the radiation, the tumor as you are lined up exactly at this point in time. And then I'm at the machine and I go, you look like you're off a millimeter to the left, a millimeter to the right, up and down. We can get as basically as close as up to a tenth of a millimeter in some cases. So we make little fine adjustments every single day right before the treatment. And this is really the spirit of what we call stereotactic. So stereotactic, again, is a very tightly conformal beam of tight conformed beam radiation, but also a tracking system that allows us to keep those fields tight. And so we have all these layers that allow us to do this. And then once we think everything is on target, we start the process, and the machine essentially begins the treatment. And within about 3 minutes, typically 3 to 5 minutes, the radiation is done. It depends on the complexity of the tumor and the shape of it and the size and what it's located to. Some plans can take a little longer, but most patients will get through this treatment in about 10 minutes each day. So we do this at our practice typically for a course of 4 to 5 treatments, meaning you'll start on a Monday and you'll be done by Friday. And when you do this, this is the part that I like the most when I explain to our patients. There's basically very few side effects associated with this type of procedure compared to historical types of treatments, which is a little counterintuitive sometimes. So we're actually giving you much, much higher doses of radiation, but because it's to a very small area, and we have a very conformal approach, we actually get very minimal amount of side effects, even though the radiation is effectively 3 to 5 times stronger than a typical course of radiation. And that's because we're treating a small area. So it's almost too good to be true. We have something that takes about 10 minutes a pop for 1 week compared to a historical 8-week treatment. It does not require surgery. And it gives you essentially, as we can tell so far in our studies, the exact same outcome as going to surgery. So this has become a very exciting technique that we can offer our patients. It's a win-win for everyone. And again, side effects are pretty minimal. Most of my patients will not notice any side effects at all during the actual course of radiation. Because radiation is an X-ray, you can't feel it, so you actually feel nothing while you're on the machine. And then it takes time for the effect to build up inside the body in terms of side effects. And so by the time you finish the 1 week course of radiation, most patients have barely begun to notice any kind of symptom. It's actually about 2 weeks sometimes a little longer, 2 to 4 weeks after radiation stops before you actually start to notice any symptoms. So that's the other thing that's nice about this, is it's very well tolerated, which again is also very good for patients who can't tolerate surgery in the first place. You know, this is not a very taxing type of treatment for patients who might not be as fit as others. So it's a very well tolerated treatment, almost too good to be true. When you do get side effects, the majority of patients get some fatigue. Usually they feel a little bit, I call it losing the pep in their step. They usually need a nap, something like that towards the end of the day. I always need a nap at the end of my day anyway, so it doesn't usually affect you in a way where you're, you know, stuck to the couch or you can't get out of bed. It's nothing like that. It's typically a mild type of fatigue. Because we're radiating the lung tissue itself can get inflamed from radiation. We call it pneumonitis, which is an inflammatory change to the lung tissue itself, which patients essentially describe as like a bronchitis. They get this kind of dry cough, potentially tightness, wheezing. Think of like a smoker's cough. That's essentially what can happen. Most patients don't actually get that. The majority of patients, like 90% of patients, will usually not tell us they feel any symptoms. About 10% of patients will develop a mild cough and some fatigue. The rib cage, if the tumor is up against the ribs, the rib cage can technically get a little bit of radiation where the pleura, or the lining of the lung, gets irritated. And if some patients may understand the word pleurisy, pleurisy is essentially inflammation of the lining of the lung. So when you take a deep breath, it catches you and you feel like you have a little bit of like a stitch or a stab in the side when you take a deep breath. That's another risk factor. Because radiation is localized, it is not filling up the entire room, so to speak. If we do not radiate your head, your hair does not fall out. If we do not radiate your stomach, you do not get nauseous or sick to your stomach. You do not glow in the dark with this type of radiation. And I've been asked many times, do I have superpowers after this kind of radiation? And sadly, the answer is no. So it's a very localized form of treatment with a very, very well-tolerated regimen, minimal side effects, and has the same efficacy as surgery. So as you can see, we're very excited about this, and we can offer this to our patients. Not all patients are candidates for this. As I was saying earlier, this is really reserved for patients with stage 1 lung cancer. Typically, we prefer if the nodules are 3 centimeters in size or less. Those are our best results. You can use this technology on patients with up to 5 centimeter tumors. When you use a radiation like this on a patient with a tumor greater than 5 centimeters, you run a much higher significant risk of side effects. And that's because radiation, essentially, side effects are predicated on how strong of a dose you give and to what area you give it. So if the dose is high and the area is big, then that's when you get the worst symptoms. So we learned that in our studies that you can't use it for patients with tumors over 5 centimeters. It's also not used currently for patients with positive lymph nodes. There's a study that was just, that is actually being completed now, looking at what we call dose escalation. So still giving you 5 treatments, but giving even higher doses of radiation within those daily treatments to structures in the middle of the lung. So these are tumors usually in the periphery of the lung. We're now asking the question, can we use this kind of radiation to tumors in the center part of the body called the mediastinum? And the answer is, up to a certain dose, yes. We are getting stuck at a particular dose level because the studies are showing early results that higher doses are too dangerous for critical areas like the heart, right over the heart. So we think there's going to be a slew of studies coming out in the future that are going to investigate using stereotactic radiation to a peripheral tumor, if it has a single lymph node in the middle of the chest, to also use stereotactic radiation to the lymph node in the middle of the chest, and then such patient would likely go on to chemotherapy, for instance. That's going to be the future studies, whereas historically, that particular patient would be treated on with a daily radiation regimen with chemotherapy for up to seven weeks of radiation. And we know that the local control rate of the radiation without this technique is much inferior to the stereotactic technique. So we'll see how that ends up going in the future. But that's basically my full overview of stereotactic radiation. We offer this in all of our centers at Ironwood Cancer Center. So I'm in our Scottsdale office, but this is available in all of our centers: Glendale, Scottsdale, Chandler, Gilbert, and Mesa. Those are our main radiation treatment centers across the valley, and all of our physicians are trained in this and have experience. So you can get this at all of our centers. And I think that concludes my presentation. And at this point, we usually open it up for any questions for a Q&A session.
Great, thank you so much, Dr. Ambrad, for all of that very helpful information. We do have one question here for you. If I have had any radiation in any other part of my body, is radiation not an option for me for future occurrences?
This is a really good question. The short answer is yes, radiation technically is an option. You can re-irradiate the same areas that had previously received radiation. It just depends case by case on exactly what was done the first time, where the treatments are given, meaning what part of the body are we treating. If it's the lung, for instance, and they have undergone a stereotactic procedure, there are some studies coming out now looking at re-irradiation with stereotactic treatments, but most of those patients, if they need radiation and there's no other option, then we will give them a different type of radiation, but we can re-irradiate patients who have received areas of radiation before. This stereotactic approach often is utilized for patients who underwent conventional types of radiation and now have a recurrence very close by, and we want to minimize and really spare the dose of radiation to other structures. We will use stereotactic if it's appropriate. So you can undergo repeat radiation. The real answer is that it really depends on where it is and what was done prior to that.
Okay, we do have additional questions. How do you know if a patient is lined up correctly for the radiation?
So, so the simulation process that I discussed is kind of the dry run, which is the position that we try to get the patient in every time they come in for treatment. So we are trying to essentially mimic the exact position they are in for the first day of setup for the mapping. So what we do is we use a device called a vac lock, which is essentially a beanbag like from the 70s that you suck all the air out of, and it just conforms to the body in a mold-like fashion. So a patient will kind of settle into this kind of cradle every day in the exact same position. Then we have their arms resting on a device so they don't have to hold their position. So it's really a passive type of positioning where the patient doesn't have to do too much work. So we have kind of rigid setups like that. We use a device, like I said, called a compression device, so the breathing motion is minimized. We use a set of lasers to line patients up in the room. So we have like a stereoscopic kind of triangulation system of lasers. We use tattoos to help make sure those lasers are always lined up in the exact same position. So you do get a tattoo, but we do say often around here that hummingbirds and roses will cost you a little extra. So that's one of those are some of the measures we use. The imaging that we take for a stereotactic treatment is also a measure of accuracy. So I can literally see live where the tumor is, and I can tell the machine you need to move this direction or that direction, this direction, so many millimeters to get the patient exactly lined up at that moment in time on the treatment. And we have a technology called arc therapy that we use that essentially, once the treatment starts, it's a very rapid treatment. The treatment usually completes like within a couple of minutes. Whereas some other units or some other platforms, you can be on the machine for up to 35 to 40 minutes at a time. And we have studies showing that when you're on a table that long, you fatigue and you start to move. And so the faster we can get these treatments done, the better. So we have our technology. We actually purchased that technology for that reason. We want to make sure we can get our patients through treatments quickly. So it's a whole series and set of steps that help us line the patient up correctly on a daily basis.
Okay. And then we have, does a compression belt hurt?
Easy for me to say, I've never used one. So no, but we actually, we have a system where you can inflate the belt to a certain pressure, and the pressure we inflate it to is going to be different from person to person. So essentially the key to this whole thing is comfort. You have to be comfortable. You do not want to be rigidly holding a position or feeling like you have to move or work at it and be uncomfortable, because then you will actually move when we're doing the treatment. So all of our patients get a slightly different setting. We do have a standardized pressure setting, but if it's too painful or too uncomfortable, we dial it back, or if it's not doing enough, we increase it. Most patients do not complain of pain when we do the compression belt, but they do notice, a device that kind of stops them from taking a deep breath. So it is noticeable, but it's usually not painful.
Okay. And then, are there any restrictions on activities while the patients are on treatment?
Generally, no. For our stereotactic treatments, again, these are quick treatments and you're done in a week. The only restriction medically is usually chemotherapy. So we do not use this type of radiation typically for the lung concurrently with chemotherapy. Some patients come to us in certain situations. We are using this in metastatic disease. So they have a limited metastatic tumor, so they're not early stage, but they are a well-controlled metastatic patient who often will be on chemo, and we have to pause the chemo for this treatment. But they also can be on something called immunotherapy, which we may have some talks about immunotherapy coming up, and that is actually safe to deliver on this type of treatment. So we typically will avoid chemotherapy. In terms of the day-to-day for the patient themselves, there are no restrictions that we place. They can drive themselves here. Again, you're not radioactive, so you can be around family members, loved ones, pets. There are no medication changes you have to make. There's no dietary restrictions. You can have a glass of wine or a cocktail. I get asked that one a lot. There are basically no restrictions for this type of treatment.
Okay, and then how can I better deal with the fatigue to make it easier during radiation?
This is a tough one. We don't have any well-defined regimens for fatigue, to be quite honest. What I always tell my patients is to keep active. Don't stop yourself just because you're getting the treatment, unless you've listened to yourself, but don't just sit around and do nothing. Just stay active, stay moving, do your routines. That usually helps. Exercise is okay. That will help. Rarely do we have to use medications like stimulants and things like that to help with the fatigue, because the fatigue is typically fleeting from radiation. It can linger for some time, for a couple of weeks, but in almost all cases, it eventually goes away. And it's usually not a debilitating type of fatigue. So we always tell patients to just make sure you're active, exercise, hydrate, kind of, common sense things. Actually, there's not much in terms of medications that we would use typically in this situation.
All right, and this last question here is, will the tattoo from the simulation be permanent?
Yes, the tattoo is permanent. They can technically be removed, but my understanding is removing a tattoo is a lot more painful than giving you a tattoo. This, I don't know if you can see here, I don't know if you can appreciate that little dot right there next to my finger is a tattoo. So I've tattooed myself to show my patients. It's a tiny little freckle. It is using tattoo ink, which is permanent. There are ways of avoiding tattoos for those patients who can't do tattoos, where we use a marker system and a series of like Tegaderm and tape and magic markers, but then you can't really get that area wet or lose those marks for about a week. So when we tell patients that, they usually do the tattoo.
Perfect. Well, thank you once again for your time, Dr. Ambrad. I appreciate all the information you've given our viewers. Thank you to our viewers for joining us today for our virtual Lunch and Learn. Please join us next week on Tuesday, October 27th at 11 a.m. when Dr. Vadia joins us for her presentation on breast cancer myths and facts. And if you'd like additional information about our supportive care services department, website at ironwoodcrc.com or email wellness@ironwoodcrc.com. Thank you, everyone, and take care.